Okay, so we'll start off our post-break presentations. First off, we're going to hear from the Northwest team, Improving Palliative Care Transitions, Hillary, Marlene, Karen, and Beverly, and a nice post-break change to the rhythm of presentations here. Won't say any more than that. We grab the doors at the back, maybe, if you're close by.
All right. Good morning, everyone. My name is Hillary Medham, and I work for the Northwest LHIN Regional Palliative Care Program. And with me here today, we have Marlene Benvenuto, who also works for the Regional Palliative Care Program in St. Joseph's Care Group. Beside her, Karen Roberts, incognito today, but she works for Thunder Bay Regional Health Sciences Center at the Cancer Center. And Beverly Kelly, who is a manager with the Northwest LHIN in the Home and Community Care Division. So like Alice said, our project is around improving transitions in palliative care in the Northwest region. We chose this project because we hear over and over again about the lack of coordination and communication amongst providers, particularly for people who are living in community with complex care needs. And so we decided we wanted to focus our project in this area.
So hello, everybody. I can see you're all curious about our fortune teller, our special guest. I'd like to introduce Madame Zelda. We've asked her to join us today to provide us with some of her predictions, seeing that in the past she's been dead on. So throughout our presentation, we will be asking Madame Zelda her predictions to a few of our questions. So starting off, Madame, will we get consensus from our stakeholders on where to focus our change idea?
Let me consult my magic 8-ball. The outlook does not look good.
So as you guys may recall from our previous presentations, we went through many iterations of change ideas and theories. We spent a lot of time talking to our different stakeholders about what they thought we should be focusing on, all around the theme of coordination and communication, but we got a lot of different feedback from everybody. So finally, we landed on the theory that improving the flow of information from the LHIN Home and Community Care to patients' most responsible providers in community was the area we would focus on and would lead to better overall care for patients and families. So that led to our aim statement, which was to have 60% of most responsible providers with patients who are considered complex to receive a formal communication from the LHIN describing their patients' home care and support services.
So Madame, do tell. Will we be able to effectively engage stakeholders in the development of our change idea?
Reply is a little hazy. Try again later.
So we did spend a lot of time in the diagnostic phase of our project, so we're just kind of continuing implementation right now. Basically, we spent lots of time talking to people, learning more about the problem, how to test our theory, what change ideas could be implemented. So some of the things we did as part of the diagnostics included conversations with providers, both in hospital and community. We did an online survey with the palliative care physicians of Thunder Bay and got, I think all of them responded to that, so that was really good to get their input that way. We also tracked the number of queries about home and community care services that physicians were raising on our daily palliative care bullet rounds. So we found there were lots of questions being asked from physicians about who their client's care coordinator was, what caseload they're on, who the nursing provider was. So that kind of led us to our change idea around improving the information flow.
Based on the diagnostics we completed, we decided to try implementing a formal communication between the LHIN Home and Community Care and patients' most responsible providers. We created a one-page letter that the care coordinator would send to a patient's MRP following every home care assessment. The health partner letter described the home and community care services the patient was receiving, the presence of other supports such as a backup plan to hospice or long-term care application, as well as the phone number and the name of the community care coordinator. Our first test of change was done with one community care coordinator from the complex care team who sent out the health partner letter to the MRPs of all of the patients on her caseload. To measure this first test of change, we sent out an online survey to the MRPs who had received a health partner letter for at least 2 of their patients. This included 5 primary care providers, 2 palliative care physicians, and 2 geriatricians.
Madame, you're up again. Will the MRPs who receive a health partner letter find it of value to their practice?
Let's see. Without a doubt.
The MRPs who responded to our survey did in fact indicate that the information in the letter was useful and would make them more likely to connect with their patient's care coordinator to discuss their care plan. Our next step was to expand the test of change to other care coordinators on the complex care team and gather their feedback about the process. Both the MRPs and the care coordinators have now provided suggestions for additional information that they feel should be included in a future iteration of the letter. Based on the feedback, we will refine the letter and implement it with other caseloads who manage clients with complex care needs, for example, patients who are end of life or medically fragile.
Madame, please tell us, will this initiative be a driver for improved communication and coordination for complex and palliative care patients in the community?
Let's check. It remains to be seen, but it looks most likely.
One of the challenges of this project is, of course, that it is difficult to change people's behaviors. We've given providers the information that they said that they wanted, and now it's up to them to decide how to use it. Another major challenge that we noted within our work on the ideas team is that the challenge of the time it takes to get together, as other presentations have suggested, specifically because we all come from different organizations. As a result, it has been difficult at times to manage the expectations of our executive sponsors and stakeholders regarding our project scope and what we could realistically get done.
So our final advice for others starting the quality improvement journey, they're kind of cliche, but it's, be patient, trust the process, and really start small but dream big. And we started really big and then had to narrow it down, but came to the realization that starting small was the way to go.
Madame, one final question for you, please. Is going through a quality improvement process worth the effort?
Yes, definitely.
It's too bad QI is so dull and boring, eh? There's something in the water in Thunder Bay, I have to tell you, because we get some of the most inventive presentations from Thunder Bay, so thank you for that. And a new standard has been set for the rest of you, by the way. Costumes are expected. Panelists too, costumes, yes. What are your questions or curiosity, comments?
My comment is, when I came in this morning, I was trying to figure out what TV show this reminded me of, and it wasn't Dragon's Den, because nobody gave me money I could give away. So I think it's Canada's Got Palliative Care Talent.
Comments, questions from the group? What are you thinking, guys? Where do you get a Magic Ball? What's the weather going to be over the weekend?
Will it pass through security at the airport?
Almost didn't.
Who's got a comment? I'm sure you do. Yes, right here. Wait for the mic. Here it comes. Goes on the run.
I have a question. What were the changes that the physicians would like to see added to the communication letter?
The original changes were whether a long-term care application had been completed. I think we had hospice originally. I'm just trying to think what else, sorry. Oh, the date of the last assessment, so how recent that it had occurred. I think that was about it.
Yeah, there were a few things I think the doctors wanted to know that wouldn't be possible to provide as well.
Sorry, I remembered another thing. We included whether nursing was involved, but they wanted to know the frequency of nursing.
And I think the individual nurses' names from the agencies as well was a suggestion.
Yeah, that was a suggestion, but we decided that that wasn't something that we could provide, given that the nurses change.
I thought I heard you say that this was sort of an iterative thing, that there was an initial letter, and there are subsequent letters that would go out, is that right? And how did that work, or what was the content of?
Yeah, so we created a letter together originally, and then we sent it out to the 5 palliative care physicians for their feedback, because this was some information that they had been requesting and saying would make their practice better with these palliative care patients. So based on their feedback, we changed the letter, and then we started using it with one complex coordinator, and then she provided feedback, we changed the letter, and then we've started using it with 5 other coordinators, and they've now provided feedback. So we're just kind of trying to find the sweet spot of all the information that they need that is not too much that filling out the piece of paper becomes too cumbersome, but also provides the valuable information that they need.
Yeah,
So I just wanted to ask, and maybe you mentioned it, if I missed it, I'm sorry, I was probably distracted by the awesome costume. How did you link this with the Health Links, the coordinated care plan? Because I know, at least in many areas, that work is really underway, and it's doing a lot of engagement, and some of it, there seems to be some synergies. So can you comment on that at all?
Yeah, no, we didn't link it with the Health Links at this time specifically. At the Northwest LHIN, I think it might be different in some other LHINs, our coordinators aren't completing the coordinated care plan right now. We have a specific individual who does that and that alone. So it isn't really linked at this time.
Okay. All right, thank you.
Madam, one more question. Will the Leafs win the Stanley Cup?
Oh my gosh, that's too hard. I'll say this year, outlook is good.
All right, and as the future moves to alumni, documentation of discussions of advanced care planning, goals of care, and consent to a plan of treatment in long-term care. Carol, James, Harinder, and Nadiria, and Anita is adding a member to the team off on maternity leave now.
Okay, so thank you. This is James. He's with the Mississauga Halton LHIN in quality. And Harinder is one of our team members, but transitioned to another long-term care home. She was originally with Extendicare. And Nadiria, I'm Carol Sloan. I am a palliative pain and symptom management consultant, as well as a multidisciplinary clinical co-lead, I know it's a mouthful, with the Mississauga Halton LHIN. So in our project, we wanted to focus on this project so that the personal and health care wishes of residents would be honored, and so that individuals would be given all the information they needed to make informed decisions about what they will or will not consent to in their plan of treatment. And this also would ensure that the laws for obtaining consent are actually followed. So for just a moment, if you would imagine with me, your mom has Alzheimer's and is admitted into a long-term care home. She is sent to the hospital where it's arranged to have a G-tube inserted. You weren't informed of the side effects and risks related to the G-tube, nor what to expect in the future. You find out later that difficulty in swallowing is part of the natural trajectory of Alzheimer's, and in fact, your mom is approaching end of life. You would never have allowed the transfer to the hospital for the G-tube had you known that this was part of the end stage of the disease. And it wasn't until your mom got an infection and pulled out the tube that you actually have an opportunity to say, no more. It's an upsetting story. I'm sure that many of you could probably tell similar stories. Unfortunately, it does happen, and it happens too often. So when we started the project, we hoped to reduce the number of transfers to the ED from long-term care, but we quickly learned that we too also had to narrow our aim. So our theory was that if we improved the quality of conversations about advanced care planning and goals of care and consent, that it would reduce the ED transfers. To that, our aim statement is today, by October 26th, that 95% of the residents of Extended Care Mississauga would have documented discussions on advanced care planning, if applicable, goals of care discussions leading to consent to a plan of treatment. So in order to understand more about our project, we did a resident survey and had some conversations with residents. However, the information that we obtained wasn't significant or wasn't sufficient to be significant. We reviewed what informational booklets and brochures were given to the residents and the families. We did a process map of what the current pathway for obtaining information about advanced care planning, how the person's personal and health goals are or are not discussed during the informed consent process. And this proved to be our most advantageous diagnostic tool, as we could then better understand why information was not being conveyed and why conversations were actually not happening. So based on our understanding of the baseline data, we decided to create a new clinical pathway. We ripped the Band-Aid off, removed all the levels of care forms, which actually we know aren't legally binding anyway. We changed the admission process to include information and brochures for the residents and their families about what palliative care is in long-term care, about advanced care planning, what the role of CPR is, and the role of the substitute decision maker. We also changed the admission process from 6 to 4 weeks. We developed a toolkit of resources for each unit in the home. Some were for patients and families, and some were just for the staff. We developed an educated and supported staff to encourage fulsome conversations of goals of care and the documentation part so that it's compliant. We developed a number of quick reference guides for the staff re-consent and refusal of consent for CPR and for having goals of care conversations. The education was mandatory for all the staff. So it was mandatory. We did education for PSWs, nursing, NPs, and physicians. The nursing education was on consent capacity and also included a mock admission in which the goals of care conversations occurred and then they had to document. The PSW education was on end-of-life care and conversations with families, and the physician education was on goals of care conversation, and then we discussed about the documentation. Our tests of change were the pre- and post-education surveys, and they resulted in showing us that there was increased knowledge of the PSWs in their comprehension of end-of-life care, and an increased comfort level with having conversations or discussions with families. Often they're a little bit apprehensive to have discussions. Nurses had increased knowledge and comfort level of providing end-of-life care, as well as increased confidence in communicating with family and answering their questions around end-of-life care. Physicians had increased comfort level in having the goals of care conversations, and then the documentation. And increased comfort actually in communicating with family and answering questions around end-of-life care. So we developed these quick reference guides for consent for CPR, and they were felt to be very helpful for the staff. And so they actually suggested us making some additional ones like treatments around hypodermoclysis, etc. And the ability to have a toolbox of resources in each of the units at the staff's fingertips when they needed was also felt to be valuable. So despite losing 2 of our members, Anita, who's off and hopefully watching, with her little baby boy, and Harinder, who transitioned to another long-term care home, we're glad to say that we're more than halfway through. Our target is not quite reached. We're at 65%, but 90 out of the 140 residents now have documented discussions around advanced care planning, goals of care, and consent to their plan of treatment. So our next steps will be to continue the project, obviously, and reach the 100% of the residents who will have that documentation and the discussions happening. And we're hoping to meet with Extended Care Corporate. So if we could see if there's a possibility of putting this into all of their long-term care homes throughout Ontario. And they have quite a few homes in Ontario. We will continue to collect data on the documentation of the discussions, and we're looking for an opportunity to have one of those steps in our clinical pathway as a forced function, meaning that they can't, or it'll put up a flag if it's not done. We also want to look at the ED transfers, because we know that it'll take about 18 months or so before we're going to see the system change, and so we need some more data on that. And of course, we want to spread it to the homes that would like to also improve. In addition, there's lots of other changes that could help and move the aim of reducing the transfers, such as having the home and community care coordinators and physicians starting the conversations about advanced care planning much earlier, before they get to long-term care. And of course, there are other things that will help move the big target of the transfers, and those are the common things like the UTIs and the pneumonias, et cetera. So our biggest challenges were that when we examined the clinical pathway that we needed to make changes on, it took us longer than expected, because some of the information we were looking for was scattered throughout the documentation and or non-existent. So also, if we had done a little bit better planning for transitions of staff, no pointing fingers, Harinder, it would have helped us in this project. And darn that, Anita having a baby. We also recognize that despite our best efforts, that there always will be a portion of individuals who will always choose, for whatever reason, to be transported to the ED. So our advice for others who are embarking on a QI journey is, don't be intimidated by quality improvement. Do small steps of change over time, and this can create a very worthwhile experience for the resident and or client, or depending on what you call them, for the healthcare provider, as well as for the healthcare system.
Excellent. Thank you. Great to hear some conversation about spread. Excellent. What are you curious about?
You've alluded to it. How do you engage the administrative and corporate structures within, because in long-term care setting, I mean, you're describing sort of, home-wide process change, and how do you engage those structures?
So for our project, and I think every other project, it's really important to engage the person at the top. So in our project, we engaged the executive. And so they have the links to the corporate, and they can have that talk. And we actually have had a talk about one of the other programs that they're doing that could dovetail nicely with this. But I think it's really important that when you're having those conversations that you're looking for the right people. And leadership does start at the top. So we really do have to engage with the corporate. Because there are a lot of corporations. Some are regional homes and some are corporations. And you really have got to start there.
Just to add to that, initially when I was actually part of this project was presented to our regional director. I was part of that, and then that regional director has 9 extended care homes under her care. So they were very excited to see the project. So and they were hopeful at that time to see the outcome of the project. And then I believe that looking at the outcome, they would be positive to implement throughout their homes.
Thank you. This is a great project. And my question is really about staff turnover. And if you've thought about, you've put a lot of effort into educating the providers and providing that capacity building. Have you thought about how to do that as staff turnover happens in the homes?
Yeah, like everything else, education isn't a one-time thing. The advantage of doing education, no matter where that person goes in our healthcare system, hopefully they'll take that with them. But yes, it will have to likely be repeated. But the fact that we have a new clinical pathway will help them in knowing that they have to know this before they can do their job. So that's the key, right?
Yeah, Lee, go ahead.
It's great. This is really a nice piece of work. I wanted to ask, you started off thinking about reducing ED transfers, and you ended up here.
Yep.
How did you end up here? And was there anything else you were considering focusing on other than this? I mean, it's very logical where you ended up, but I'm just
Yep.
curious if there was anything else.
Well, there was a High report in 2014 that actually talked about the fact that people were looking at having goals of care conversations as one of the key things to helping reduce the ED transfers. And quite frankly, I have a passion for advanced care planning and healthcare consent. And so that seemed to be a natural fit. And this particular home was very keen on doing a quality improvement project. So when I bounced the idea off them about what they wanted to do and would this fit, and they were very enthusiastic about it. So you got to go where the enthusiasm is.
Congratulations on your work. And just as a bit of an extension of the comment or question that Angelica brought up, by way of the education piece, I'm wondering if you might be able to elaborate a bit on how you identified what education may be helpful, how you developed it, and how you rolled it out, knowing that, at least from my perspective, working in a large hospital organization as a nurse practitioner, it's often quite difficult to get people to the table for education. Could you comment a bit on that?
Sure. The key was it was mandatory. So, and that's why I talk about leadership at the top, that you have to engage them. And quite frankly, I wasn't sure that we would get all the physicians there because of course, somebody else mentioned this, it was during the summer and everybody had vacations. Some said they couldn't come, but in fact, they all showed up. So I think if we look at it as a system change, regardless where we are, and think that we have to make it so that everybody has the same information, so we're all doing and saying the same thing, because that's a risk as well, as if we don't all do it and say the same thing. That's why the cheat sheet for goals of care and the discussion about consent for CPR was very helpful for the staff. Then we're all talking the same language, but key is mandatory.
Great, thank you.
Excellent. Thank you, and become alumni. Forced functions do work, right? Timmins Palliative Integrated Care Team, Jennifer, Patrick, Celine, Marnie, and Nancy. Just getting their best side.
Well, good morning, everyone, and thanks, Alice, for the introduction. So, we've been asked to tell our story. So, once upon a time, in a northern city far away called Timmins, there was a very skilled group of palliative care service providers who decided that they wanted to collaborate in order to build a more integrated team that would deliver palliative care services to patients with life-limiting illness. They were very fortunate to have the opportunity to participate in IDEAS as a sponsored project from the Northeast LHIN, and to have highly engaged executive sponsors and health organization administrators. Through participation in IDEAS and the requirement consequently to move their idea forward, the Timmins Integrated Palliative Care Team was formed, and the rest is now history. Timmins is a community of 41,000 people. As health service providers, we are aware that additional funding for services is very limited, particularly in the north. The Timmins Integrated Palliative Care team recognized that there may be efficiencies that could be gained for the care of our patients by providing services in a coordinated, integrated fashion. In order to ensure that all patients with a palliative diagnosis had access to the integrated team, we chose a project for ideas that endeavored to facilitate earlier identification and referral of patients with life-limiting illness so that care could be provided by the integrated team earlier in the patient's trajectory. The project has held significant importance for many of us in the Timmins community for many years, yet we lacked the right tools, relationships, and provider engagement to drive this project to action. We wanted to focus on this project because we had long ago determined that although there were various agencies within the community capable of offering palliative care services, these were in fact fragmented as providers were working independently and often in isolation. Beyond these services, there has never been funding for a formalized program or structure in Timmins, and still isn't. We felt strongly that we could positively impact the delivery of palliative care, as well as improve the efficiency and effectiveness of these community agency services through a sustainable, collaborative, and integrated model of care for all involved, including patients, their families and caregivers, as well as the various health professionals rendering care. Our goal was to develop an integrated palliative care team by utilizing existing community healthcare resources with minimal added cost to the system. This would be done by bringing these providers together physically under one roof, while maintaining their agency affiliation with hopes of improving team communication, collaboration, trust, and service planning. It was our theory that early referral to the Timmins Integrated Palliative Care team would result in better coordinated care for patients and families. It would increase their quality of life and allow them to prepare for their end-of-life journey. We also hoped it would promote the engagement of primary care providers to work in a collaborative model, allowing consistent and comprehensive care along the patient's illness trajectory. At the same time, we hope to improve team efficiency and patient care transitions while reducing duplication of such limited resources and services. And that led us to our aim statement, which is, by October 1st, 2018, 20% more patients with a palliative diagnosis will be referred to the Timmins Palliative Integrated Care team greater than 3 months before death. In addition to the development of the aim statement, we further identified 4 key drivers that would serve to guide our work and ensure that we remained focused on the core issues. These elements included defining educational needs, refining our referral process, improving care transitions in the community, and improving access to the integrated palliative care team. In order to understand more of our project, we used diagnostic tools, including a driver diagram, a process map to assist primary care providers with early identification, and we revised the referral process to the integrated palliative care team to make it a little more efficient. To gather valuable insight into the current state of care delivery in Timmins for patients with a life-limiting illness, we first needed to identify gaps and barriers in our existing model or practice. This was accomplished through surveys designed to elicit information on key elements for our project, and was achieved through primary care provider and patient feedback surveys. So we gained an awful lot of interesting information there. Specific questions were developed to elicit information, including a primary care provider's understanding of the definition of palliative care, their perception about optimal time of referral, and availability of and access to existing resources. In contrast, patients and families were encouraged to share their perceptions regarding satisfaction with the time of referral, care provided, their knowledge and understanding of available services, and their ability to access these. We further conducted a retrospective data analysis that considered PPS score at the time of diagnosis, the diagnosis itself, the duration of stay in the program from the previous 12 months. The patient surveys concluded that patients felt that the Timmins Palliative Integrated Care Team involvement provided them with enhanced quality of life and support during their illness while providing seamless and coordinated care. Some patients and families wished that they were referred earlier in the diagnosis. Based on the diagnostics and tests of change we completed, we decided to focus our attention on building capacity amongst primary care providers through education. It was evident that there was a significant discrepancy between perceptions regarding the definition of palliative care, tools used for the purpose of earlier identification, the benefits of earlier involvement of palliative care services, their knowledge of existing resources, and the optimal time for collaboration, as well as the best method to engage available services. We proceeded to develop an educational interactive education session for all primary care providers in our community. Feedback from these sessions allowed us to further tailor these presentations to specific audiences in order to foster a receptive and collaborative model. Feedback is continuously being gathered and evaluated accordingly, and we'll continue with some of that work. In addition, we developed and utilized weekly collaborative bullet rounds and a patient database to help improve team communication, collaboration, co-management, and care planning. We recognized several challenges, including the need to continue to work at resolving system and organizational barriers, the creation of a common EMR, improving EMR functionality, and ensuring primary care providers and service providers' engagement in this process and their adaptability to the new model. Lessons learned were that despite these challenges, we go forward having accumulated a few pearls of wisdom. Although patients with a cancer diagnosis are readily identified, there are many more patients with other life-limiting illnesses that are being identified much later in their illness trajectory. We need to focus our efforts on these individuals as well if we truly hope to achieve earlier identification and provision of a palliative approach to care for all patients with life-limiting illness. For many primary care providers, the word referral is often synonymous with transfer of care. This we discovered in our education session. In order to build capacity, we need to be aware of terminology and perhaps change the word to engagement or involvement in order to promote a collaborative model of care. Thirdly, it was recognized following our first education session that primary care providers were engaged in wanting to access our services immediately going forth. It is of extreme importance for the sake of sustainability and adaptability to ensure that the technical capabilities for referral, in other words, referral forms, are ready for use as soon as you introduce them. We learned that it's important also to be open to possibilities, to think outside the box, explore care models and options. We recognize the value of having ongoing mechanisms to capture patient caregiver feedback, either qualitative or quantitative, in order to evaluate the effectiveness of our team and the palliative care services rendered. Many stories must come to an end, but not ours, at least not for now. Participating in ideas has created the momentum that we feel we needed to impact change in our healthcare system for care of patients with life-limiting illness. Finding efficiencies through the development of integrated community care teams ensures that care to patients is maximized. In addition, there is no doubt that this model could be replicated in many other patient care scenarios, particularly in smaller communities. Those of us that are responsible for the delivery of many different programs definitely have our work to do. So thank you for the opportunity to tell our story.
Excellent. I'm glad to hear there is no the end. This is good. Panel, what are you curious about?
Well, beyond curiosity, I think I could have saved myself a lot of time if I'd asked you folks to write the framework, because what you've described is what the framework is going to look like. One of the questions, and I've heard you present earlier this year, and I think it was Dr. Critchley, I think you had mentioned that the experience of working as part of a team was particularly gratifying And the question I had was, what was different now than whatever was before? How is it qualitatively different?
Well, I think before we started, just as Jennifer alluded to, we were providers in different agencies, all doing palliative care. There was no sort of leadership or direction for planning or change. And I think that this opportunity has brought us all together in order that we're working together, we're communicating. We were meeting every Friday for about 3 hours. So we've become a team. I think that Marnie, who's the nurse practitioner in the community, was, if I could speak for you, feeling a little bit overwhelmed. She does community palliative care. And I think just the fact that there's a team around her as well supporting her has made a big difference, I would say. So there's lots of changes. I don't know if anybody else wants to speak to that. Nancy?
I'm a palliative case manager in Timmins. I had the opportunity to be co-located to the family health team almost 1.5 years ago, and what a special experience for me. We have a dedicated room. We make a time slot every Friday morning, and we stay true to it. And yes, summer was challenging. We all had time off. And everybody knows in this game, you have to take your time off in the summer. It's what gets you through the rest of the year. But what a special experience. And I'm just hoping that we don't lose that space. Yeah, very, very special for sure.
This end of the room has been quiet. Oh, but this end of the room is going to speak, so now you're next.
My question builds on Bob's. Actually, I was thinking the exact same thing. We've got an example of the kind of model of care we're aspiring for. I'm interested in your reflections on engaging the other primary care providers in your community. You kind of highlighted what they needed to hear more about, but do you have a sense coming out of that how you will collaborate with them in the care for their patients on an ongoing basis?
I'll speak. So working as the nurse practitioner in the community, because I deal mostly with the physicians, so what we've done is we do have a contract with between the Northeast LHIN and the family health team, which allows me to access practice solutions. As we know, EMR is a huge issue for everybody. So I do have access to the EMR, and I chart on all of our palliative care patients in that system, which does allow us to communicate very nicely between each other. So myself and the physician are often communicating, but I think that it has really allowed us to engage more, for sure. I don't know if that's one of the bigger, I think.
Great, thank you.
I think the other thing is we're fortunate, a lot of the family docs in the community want to do their own palliative care. And so my name sort of in the community has been the palliative care person. So sometimes the oncologist from Sudbury, that's our closest, about 300 miles, will send me a letter to say, can you follow this patient for their palliative care, when in fact they have quite capable family doctor who's interested in doing it. So basically I call that family doctor and say, look, I got this referral, and they'll often say that they and Marnie will work together, and if they need some help, they'll call me. So most of them are engaged in doing the work. And then I just simply send a letter back to the oncologist saying, look, I'm not going to see them at this point, family doc's involved. So I think that's a really positive thing in our community.
Go ahead.
Hi, great work. I got lots more questions, but I'll just focus on one. I see all the great sort of names at the bottom of your poster, so I'm interested. So Marnie, you're a LHIN NP with the palliative team. So you've spoken how you've got kind of access to the EMR. That's great. What about all the service providers? How are you managing that piece? Because that's great. That's a huge challenge, as I'm sure you're aware. And have you figured any of that out? Because we'd love to steal from you.
Well,
You're up.
I'm the one that's always working with all the different service providers. So I think the biggest thing is I think we all agreed that we definitely need buy-in from all of the different organizations. I think we're lucky that we do live in a small community, so we all sort of know each other. Myself and the nurses have a tremendous relationship, so we're able to work very closely together. I think every day, we have 3 or 4 that are definitely trained in palliative care. So there is a lot of consistency. We try to keep the same nurses with, you're attached to a primary nurse, so we're constantly communicating, as well as with the care coordinator. I'm on the phone with her almost every day, in between the physicians. So I think I think part of it too is the individuals. I think definitely you have to have the right, I think as a team we work very well, but we did talk about in our sustainability testing that sure, if one of us were to potentially leave the team, that might create some issues too, but.
Is that partnership formalized at all? And I know that's probably the last thing I can ask. Is there any sort of MOUs or any discussions that you had to sort of bring those folks as part of that integrated team? Or that's early days for that?
Yeah, Jen, you speak to that.
Only for the EMR. That's the only, formal document that we've actually signed. At the Timmins Family Health Team, we're working with 35 physicians. We're serving approximately 63% of the city of Timmins. So outside of those 35 that work with us, there are only about 6 or 7 family docs in our community. But there is, so really, organizations have come together in good faith to build this team. And, whether we'll need those in the future, not sure. Not sure. I think we'll have to see how it rolls out. And I think we all understand that this is really for the betterment of patient care, and we know we can impact that.
Great. Thank you.
Excellent. Thank you. As you become alumni. Things can happen in the north. I think this might be the longest title, at least there's a lot of P's in this title. Primary level of palliative care integration with prevalent patient population. That's alliteration. Your grammar teachers would love you to know that. At dialysis clinic in Aurelia Soldiers Memorial Hospital, Rebecca, Corinne, Michelle, and Susan. We'll just give these guys a chance to get their photo. They may have done this before, eh? Look at that line.
Okay, good morning, and it's almost lunchtime, so we will try and stay on time here. Thank you, Alice, for reading off our project title so that I don't have to do that. So basically, when we started to focus on this project, it was because there's current data that shows that many dialysis patients receive very intense care in the last days and weeks of their life, and often don't die in the setting of their preference. For example, many of them actually end up dying in ICUs when the preference was to pass away in their homes. So with this project, we are hoping to have some impact on patients and their families. Patients and families are entitled to receive the care that they want. If we're not taking the time to ask patients what they value and what their hopes are, then we can't give the best possible patient-centered care. It's one of our main things. So our theory was that patients and clinicians wanted to have these conversations regarding patient values and goals and hopes, but neither the clinicians or the patients were really stepping up to it. So what we needed to do is sort of coach them to initiate these conversations. We felt that providing a mentorship model for the clinicians would be most effective in supporting the staff team to lead these conversations with increased confidence. And this would also support sustainability and spread in the future. And this led to our aim statement, which is, by November 1st, 2018, 50% of the prevalent patients receiving in-center hemodialysis at Aurelia Soldiers Memorial Hospital would have a goals of care conversation documented in the electronic medical record. In order to understand more about our project, we reviewed current literature about goals of care conversation, particularly in the renal population, and reflected on a study that was done at OSMH, replicating the work of Dr. Sarah Davidson from the University of Alberta. We also did baseline surveys with clinicians and the patients to gauge the readiness, understanding, and willingness to engage in these conversations. And we found the following resources to be helpful for understanding more about contributing to issues that were contributing to these things. So one was the Core Ideas project members who work at OSMH. The second was leadership teams at OSMH, as well as with the Palliative Care Network. And one of the important ones was having a nephrologist who was identified as a palliative care champion, which we'll talk about later as far as bringing this into the process. And getting a baseline understanding of the barriers that had existed previously and strategize how to overcome during this project period and beyond. And I'm going to hand it over to Corinne, who's one of our social workers in the kidney program.
So based on the surveys that we did and our baseline data and the Pareto chart that Rebecca put together for us, we did discover that mentorship was very popular. And so we did this using external subject matter experts and then internal staff. And because social work has been promoting in advanced care planning and harping on palliative care for many years, the staff were sort of familiar with us, and the process was very easy to implement. It helped us understand what challenges people had doing these conversations. It was not an easy kind of conversation to have, and we do have tools that we've developed as well. We also have tools from the Ontario Renal Network, so we were a little bit ahead of the game. And I'd also been doing some in-services about why we wanted to do this, so everybody was sort of prepared for this process. When we started doing the mentoring and coaching, we found that it was a very positive experience for both the staff and the patients. The patients loved that we were actually pulling up a chair and sitting down and taking time to talk to them, and the staff also found that a very rewarding experience. So what then happened was we introduced a new electronic medical record. So we've had many challenges along the way, as many of you have. But part of the mentoring then could become, here's the tool that we're using to document that we can then report to the Ontario Renal Network. And part of the mentoring was how to actually put it in there, as well as how to document the code status, which we were asking, and the substitute decision maker. So it was all part of that mentoring. We also had the opportunity, because our advisor wanted us to make sure, emphasize that we needed a nephrologist on board, our clinical champion for palliative care was willing to also have some mentorship from us. And so we did go through that process with him, and he was pleasantly surprised to find that it was more of a conversation. He also engaged with us, pulled up a chair to speak with the patient, and we did have someone accompany him to provide the coaching, but also to provide some other information he may not have known about the patient. And so this is what we're also encouraging the nurses to do. They can go together to do some of this mentoring. To further support the patients, we've created the opportunity for a standing presence in our unit from the Palliative Care Network nurse that we've been working with for several years, and this allows the patients and staff to become comfortable with her, familiar with the resource, and also to support the staff in having these conversations along the way. She also provides symptom management, and we're hoping, and we've seen some increase in referral to palliative care, which was also one of our goals, to have that in palliative care introduced earlier. So, yeah, and so hopefully we're changing the culture, right? Thank you. So you can see in this tiny little picture there that over time we were successful in meeting our aims. We're sitting at about 51% of the population now that has a documented goals of care conversation. The reason it's sort of leveling off is twofold. We are switching now from really being active mentors to encouraging the staff to initiate this on their own. So they're much slower to tackle this. And also because the ORN has this sort of as an annual indicator, we don't want all the conversations to come due at the same time. So we are trying to have a sort of staggered approach so that over time, as people's conversations come due, they can accomplish it rather than in 1 month trying to blitz through everyone. So that's why that's happening. Our palliative care referrals, the nurse started being a sort of routine presence in August, and since then we've seen her referrals triple, which is really exciting. So early days, but good signs. We did survey the staff and the patients after we sort of had initiated all this mentorship and really found that they were very appreciative. They had a lot more confidence and that they really still weren't totally ready to be out on their own and wanted more mentorship. So thankfully there's lots of internal things in place for them there. The patients really felt this was a positive experience. 94% of them really agreed that they felt they had a good understanding and that it was a really overwhelmingly positive process. So we're excited about that. So our next step, so we're starting to shift from this queuing stage of our mentorship to really having these staff feel empowered to initiate these conversations on their own. We're trying to help these conversations follow the patient. So it's one thing to have this happening in the dialysis unit, but what happens when our patients end up in emerge? What happens when they're seeing their family doctor? So because it's all separate EMRs, we're having challenges with that. So trying to figure out how to have these conversations have legs and follow patients wherever they go across the care setting is important. We also want to spread this to our other renal satellites. So ORN has this indicator for all the renal programs. So how can we help the other regional satellites pick up on this work? And certainly Corinne is really active in visiting these satellites and has been sort of championing this work there. Yeah, so our biggest challenge is really we have an EMR, but we're still having great difficulty collecting data. So we've had sort of personnel changes, we've had a new system launched, none of the systems talk to each other, so really we've been collecting all this data manually. So Corinne is pulling the numbers, it's taking quite a bit of work. We certainly have great support from our organizational leads, but it's just slow to happen. And so they are continuing to advocate for us, so we're hopeful that actually a report can be built that allows this information to just sort of generate naturally. One of the biggest challenges was just getting started. People didn't feel comfortable. So once we've given them this training and we sort of gotten the ball rolling, we really feel like we've got momentum, people have bought in, we're gonna move forward with ease. We felt that we were quite successful in this initiative, mostly because we tried to scope it appropriately. I think a lot of groups have sort of touched on that, not trying to boil the ocean. We had lots of good organizational leads and Joe reminding us to just sort of scale down, which was really helpful. Our core team really was motivated, so these women have worked really hard within the OSMH program. And so we're just sort of capitalizing on their good work. Certainly we had great organizational support, and actually the ORN is mandating this. So we had good environmental conditions to sort of get this off the ground. The patients and the staff were both so open once we sort of approached them and really tried to frame this positively. They've really engaged, and we're so grateful for their buy-in. And I think one really big piece is having me sort of parachute in as an external motivated person from the RPCN, sort of not bound by the constraints of the organization, who could ask sort of curious questions and probe a bit, which I think really helped to drive the work. So we really want to say thank you to our organizational champions, certainly to the support of the RPCN. Thank you to Joe, who's been incredibly helpful. Dr. Xiao also was a really great consultant for us in this process. And thank you to these ladies.
Thank you. Excellent. You know, and as we hear about scoping, I just want to take you all back to that first meeting that you had with us as your advisors. And I'm sure after that meeting you thought, those people have no idea what they're talking about. Of course we'll get all this done in 5 months. I just needed to take you back there for a moment, just to think about that, right? Now scoping is a word in all our vocabulary for sure. Panel, what are you curious about?
You noted that having a mandatory indicator around this for the program was important. Do you think that'll shift over time in terms of the ways that you want to communicate information back to the team around how things are going? Sometimes the indicators don't quite connect to the clinicians' points of passion or concern for their patients.
So my experience has been, because I've been very passionate about a lot of this for a long time, is that it's the way you sell it. And we really were teaching and coaching that this is something that the nurses were already doing, having these conversations. We know our patients very well over a long period of time, and this just enables them to actually document this and hopefully follow a plan of care that the patient wants. So, yeah, I think we've got really good buy-in. Yeah.
I would just add to that, I think while it's mandatory now really helps us get things going, really hoping to shift the whole culture. So because we've got this impetus to get it going, hopefully us implementing this will help just sort of transition to this being the sort of baseline level of care that people would provide, is our hope.
I'm just reflecting on my experience in the cancer system, where sometimes there were far more important pieces of information that were valuable to be feeding back to the team. The indicator was important to track, but there were other sub-processes that were important to monitor and give feedback around that really reflected the kinds of work and efforts the team were doing.
At that end of the room, because I'm realizing that end of the room has done their presentations. Thank you. Oh, are we going to fortune tell something?
I'm assuming your patients are outpatients, so I'm just wondering, once you've documented that plan of care, knowing that patients' goals of care may change over time, how often do you revisit those conversations and questions with your patients?
The ORN has mandated that it be at least once a year or with a health status change. So right now, because we're just sort of getting into it, I am pleased, though, that the tool that we have, we can add to it. So what I'm encouraging people to do, if they see a health status change or the patient is admitted or they're coming back to us from somewhere, that we're adding another note in there.
Dialysis is a highly protocol-driven process. How did you insert this into that process? You know, I mean, traditionally sitting down and having a goals of care conversation in a busy dialysis unit can be challenging. And how do you change that culture or process?
You have very passionate people to just do it. And a lot of the mentoring, and that's how it happened, and a lot of the teaching, that's how it happened. I pulled my laptop up to the nursing station, or I said, who has 5 minutes today, or 10 minutes, or 15 minutes, and we'll go, and it may not be your primary patient, which I think is eventually the goal, is that these conversations will happen with the nurses, with their primary patients. But for now, who's here today? Who's, feeling okay that we can sit and have this conversation. So I think it's just persistence. Yeah, and realizing that this is something, if we're not actually asking the patients why they're here and explaining what's going on with them, then we're not actually providing good care. Yeah.
Danielle, go ahead.
Hi. This is a bit of a comment, and then I have a question. Changing culture is like the thing in improving quality, and it's so important, and yet it's so hard. Like, it's changing culture is like it's a hard slog. And just a comment is that I love the way you've kind of focused on that, and then you've kind of developed a bit of a plan for how you're going to do that. And I was reflecting on the language you used when you described your presentation, like the focus on mentorship, and you just have such a positive way of describing it. Really being attuned to when people felt confident on their own versus when they needed a little bit more support. And I commend you for that. I think that's really, really good. I'm intrigued about how, as you spread this, like, it sounds like you had a great culture coming into this. As you spread this to other sites, how are you kind of making sure that kind of approach to this work, so that the work really does improve culture? How do you keep that going?
So I think we've been really cognizant in how we framed it here, and that it's pretty translatable to other sites. I think people get really hung up that this is going to be, because it's a form template, that it's a checklist they have to go through and get all these things done. And we've really spent a lot of time to make sure we're framing this. This is a conversation. These are conversations that you're already having all the time with your patients. You're just not documenting it in this kind of a formal way. So trying to really stress that these are skills that these people already really have and are excellent at doing. We're just trying to formalize it in a way that gives them some leverage when things are changing, or maybe the nephrologist is making a decision that they think the patient wouldn't want. They actually have a way to sort of come back to something that's documented to say that's actually not what they've expressed. So I think we're really trying to stress that this is work you're already doing, and you're doing it very well. We're just trying to give you more leverage to make sure that you can support your patients to die where they want and get the care they need.
Excellent. And as you transition to alumni? Strengthening a palliative care approach in long-term care. I'm looking right here. Erica, Erica Gennara. Thank you. I'm sorry. Selenor, Alex, and Sandria. We'll just let them get their photo there. Good to go.
Okay, so I'm very fortunate because 2 days ago I didn't have a voice, so I am very fortunate to be here this morning. Our team is coming from Central Westland, and we have Jahanara from Central West Palliative Care Network. We have Alex from Central Westland. Sandria is from Holland Christian Homes. She's one of our frontline RPNs. Selena is our nursing supervisor at Holland Christian Homes, and myself is the director of care of one of the homes. We have 2 homes, and we started this project as an invitation from the LIN, and we didn't know what we were getting ourselves into, but as you know, long-term care is so busy. There's always something going on. And with us, we had shorter staff. I didn't have an assistant or a nursing supervisor. And in between, the other home lost their director of care. So we've been working short for a while. However, our problem statement, we started off looking at residents' transfers to hospital. And residents may suffer and have deterioration when they transferred to hospital with palliative care needs. That can be taken care at the home. This impacts both the residents and their families and may result in increased care needs for residents and increased support for families. And what we have recognized that most of the times when residents are transferred to hospital is that they come back with more issues, especially in our long-term care homes. So our goal was to look at decreasing emergency department visits would mean that the resident will stay where they are and have reduced risk of complication while receiving treatment in the home. Our aim statement was to look at decreasing transfers by 25% by October 1st, which really still working on. And so I'll have Janara come and talk about our diagnostics.
Hi, so I'm going to highlight our diagnostic journey, but before I highlight, I want to declare something. I don't remember declaring it before, but I know when we were starting the discussion about ideas, and I was discussing with my director that why Holland Christian Homes, and I don't think so you guys know, but because Holland Christian Home had the lower rate of ER admission as is. So it was considered one of the good homes. And also because all of these staff had already done LEAP. So we knew that they're aware of palliative care. Palliative care is being done there. Lower rate of the ER transfers. So still why there are still transfers happening. So we needed to know why. So we started this project journey with a very lengthy, I would say, diagnostic journey. So we not only just did not focus only one area, we actually interviewed the staffs, the nurses who were mainly the nurses who had recently transferred the patients to emergency department. We also interviewed the residents whose loved one had passed away in the homes. We also did talk to the physicians. We did survey to the staff to find out what other staff and what PSWs are thinking. So we try to catch the problems from a 360-degree angle to see where the issue is. Finally, after doing all this, we came up with a very lengthy and complicated fishbone diagram, which you can see later in detail or on your computer. but it highlighted quite few, identified few reasons that still the transfers to ER is happening. But after doing all this, what we did is we presented this fish diagram and our all the analysis and all the diagnosis with the stakeholders. So we had a big meeting with all the stakeholders, and included our palliative care network directors, home directors, physicians, and the admin staff, everyone on the table. And then we did the prioritization, what we should focus on, because there were a few things we could work on, but we needed the support. And we wanted to do something that impacts more than one area, not just one area. So we identified that, and it came up many times in the staff and the doctors' interviews, that comfort level form that were still in use in the homes could provide some, if we change those and turn into different approach of discussion of what patient wishes are, that would be helpful, and that would change staff's perception of what it is and how they can take care of patients who are end of the journey or who need the ER transfers. That would really help. So we started focusing on comfort level forms. So I'll give back to Erica to share the further journey.
So as we continue to look at our comfort level forms, we realized that a lot of the mindset from our staff was that, well, the person is a level 4, we'll send them out to hospital, or not getting the consultation or the consent that is needed at the time. Sometimes what we'll talk about later on was the on-call physician, that they don't really know much about the resident themselves, but they will say, well, it's a level 4, we send them out. So looking at that, we look at replacing the level of care forms with the prevention of error-based transfer, which is POAT approach. Ensuring that the residents' values and wishes and goals of care discussed and documented, ensuring compliance with the Healthcare Consent Act. So we looked at, although removing the level of care forms was determined to be the primary issue, reducing ED visit will take a multi-pronged approach, as highlighted in our fishbone and our driver diagram. Managing residents' and families' expectation in relations to palliative care in the home, Palliative 101, healthcare consent, advanced care planning, training for staff, residents, and families. Educating residents and family members on what to expect at the end of life with common conditions. So as during our results, we had started where we would use the goals of care and the POAT with our new admissions. So we had all of our new admissions started September. Our social workers started to use the POAT. I had the opportunity to have a new admission that had a lot of issues with his health, and he was able to sit with me and inform me of what his plan was. He knew he had 4 months to a year to live. He knew what he wanted. He didn't want to be transferred to hospital. He knew exactly who would make the decisions for him if he is incapable of doing that. And unfortunately, a week later, he passed away in the home, just how he wanted it. So some of the challenges that we still have to address is the staffing, getting the education for staff, changing the mindset of staff in regards to what are the goals and what that person needs. So the plan is to spread. The change ideas are being tested by both Faith and Grace Manor, and the plan is to spread the lessons learned to change ideas to other homes in our Central West Lynn through our palliative care network. And we'll just continue with our we're very fortunate to have a nurse practitioner in-house, and we have a lot of discussions through that with families. So when there's a change of status, there's always the goal of care. The conversation is happening, but there's no formal way of having it documented. So that's what we're doing right now. We just started our POET workshop. 2 of our staff, our social worker and our Selena, our nursing practitioner, has attended the first day yesterday for our POET workshop, and this is how we're going to transition into the future in regards to that. Thank you.
Excellent. We're glad you got your voice back as well. Comments, questions? What are you curious about? Way down the end. Run, run, run. And we want one way down here. It's a game.
Thank you. Great presentation, and that was very, very informative. And we actually got a few ideas for our own project. So thank you for that. I wanted to ask you, where do you document goals of care once you have that discussion? And you mentioned that you have this discussion on admission, and that's great. What about those people who are already residents? How do you address that? So 2 questions. Where do you document goals of cares and discussions, and how do you address discussion with goals regarding goals of cares with not the residents who are just new to your home?
Okay, so this is our pilot project. So we started off with the admissions. So what we're doing, we documented it. We have a drop down for goals of care in our point-click care. So that is all being formalized right now. So that's where the documentation. We also have the form that is being used through POET with that to list the goals of care and what the resident wishes are. How we're going to be doing it, we're going to be doing it in our conferences. So annual conferences, we're going to be doing it on when there's a change of status, looking at those conversations that we're very fortunate that our physicians and our nurse practitioner is really into this. So, and our social workers. So we have that support, and of course the support of the LIN too. So we're really fortunate for the support that we have.
Thank you so much.
Anything you're curious about?
It's more of an observation. It's exciting to see that there's several projects that are being presented today that are focusing on long-term care, and what a neat opportunity this has created, but maybe even beyond, to create more of a community practice around this. There's 12 homes in Toronto, for example, that have been working on integrating the palliative care approach, and about to be 12 more. So, I'm sort of thinking about tools that get created in one project need to get shared, so that teams can translate their changes even more quickly by kind of adapting or adopting things that have been created. So share your good work is my key message today.
Excellent, thank you. Anybody else, Bob?
As you described it, that the RNs or the staff interacting with the client or residents as they come in are having these conversations, what's the comfort level relative to scope of practice in terms of those?
So that's a challenge for the registered staff themselves to have those conversations. So that's where we're going into the education piece, where we're doing our palliative care 101. And also our nurse practitioner really takes a hold because she's in-house along with the social worker, so she drives those conversations. So that's how we get to move ahead with that.
Excellent, thank you. We'll transition you to being alumni. And just as these folks receive their certificates, I want you to all take a look at your agendas for a moment. And all of the projects up till lunch that you've heard from are basically from this table to that side of the room. So these are the folks that you want to seek out if they said something that sparked an idea in your head. You want to get a copy of their poster. You want to know about that tool. You have a friend who works at Aurelia Soldiers. You want to know if they're still there. whatever your networking may be, but we've allowed an hour for lunch because the networking portion now becomes even more important as you transition from the formal part of the classroom to your community of practice. So please seek out folks that you sort of tweak something in your memory or in your mind. Also want to remind you about the green sheets on the table. Those are your personal ahas. So please, between now and the end of the day, be sure that each one of you has completed one of those. Just fold them in half, leave them on the table. And one final community of practice reminder is find your randomized coffee trial partner today. Reconnect with them and reaffirm the fact that you're going to stay connected after today as well. So now everybody's thinking, oh, what do they look like? That's why you have an hour for lunch so that you can remember. But we will break now. There are cupcakes. It's celebration time. Even the teams that haven't presented yet can have cupcakes, yes. You guys can't have two, no. So we will come back together promptly at 1 o'clock because we'll start with our presentations and our live cast again at 1. So congratulations to this end of the room. Great presentations. And passing the baton to this end of the room for this afternoon. So enjoy your lunch and we'll be back at 1.